Yeah, okay, that's fine. So I am going to get started because today we only have half an hour, which I think actually might be quite a good formula going forward. I'm not sure.
Well, let's see then.
I've got interviews there.
How to do
so thank you. Thank you so much to everybody for joining. So this is a hybrid session. So if anything's not clear or the slides are not moving, please just speak up. It's a very relaxed lunchtime session squeezed between interviews today. So I'm really conscious that we have this global health group here in NIHR on the health, economic and societal burden of musculoskeletal disorders in Tanzania, and we haven't really spoken a huge amount about it with the pandemic and what have you. So this is a really nice opportunity for me to start reporting on some of the findings from our study, which is coming to an end in about 6 months. So, okay. So I presume everybody can see that. Oh, what's happened there? Anyway, it's a bit obscured, yeah. So just a little bit of background. This is a global health group which was funded by the National Institute for Health Research, the Global Health Fund, and we had an extended study after year 3. So we're running the study for 4 years in total. I'm leading it as a health economist, and we have a highly multidisciplinary team in NIHW, HETA. We also have social scientists. We've got colleagues in biodiversity, infection, immunity and inflammation, and also the School of Geography, as well as our colleagues in KCRI. Yep, so our main collaborators are the team in the Kilimanjaro Clinical Research Institute in Tanzania, and particularly Blandina Mbaga, who oversees the team there. We also have 2 clinicians from Northumbria and University of Newcastle. So let me just give a little bit of background. So what's the problem? So 2010 Global Burden of Disease study reported that musculoskeletal diseases account for around 20% of all years lived with disability in low and middle income countries. Significantly contributing to this burden is arthritis. Years lived with disability attributable to osteoarthritis alone rose by 75% in the years 1990 to 2013. And in Tanzania particularly, there's a huge lack of data existing on the epidemiology, economic and quality of life of arthritis. So this general sort of statement that we understand Africa is currently facing as preventable crisis caused by the rapid rise in people developing non-communicable diseases. So this brings not only clinical but economic, societal and quality of life impacts. And the measurement and valuation of these impacts is really needed to inform policy. So we know in Tanzania, for example, NCDs now account for about 27% of all deaths. However, from our perspective, and the reason we wrote this grant was that the focus on NCDs was typically dominated by other diseases such as cardiovascular, cancer and diabetes, and very little attention has been paid to arthritis, and this is hugely out of proportion to the impact that arthritis has on disability. So what's our NIHR group doing? So to understand the distribution and impact of arthritis in Tanzania, we talk about arthritis, but actually I should really say musculoskeletal conditions more generally, of which arthritis, inflammatory arthritis, is a sub-component. So to understand the distribution and impact of arthritis in Tanzania and to inform prevention and intervention plans, we have conducted a population and hospital surveys to establish arthritis prevalence, economic and quality of life impacts, and to understand and describe the lived reality of arthritis. So we've carried out qualitative research to explore the understandings of joint pain and to understand the lived reality of arthritis. We've identified and tested methods to measure the quality of life and healthcare resource use of people with arthritis. We've also built in a huge amount of capacity building. We've trained early and mid-career Tanzanian researchers in social sciences and also clinically in conducting research, but also conducting clinical screening. Nicola, do you want to turn your mic off?
Oh, sorry.
That's all right. Nice to hear from you. And we hope with our teaching and our legacy that we've developed some sustainable capacity for tackling a wider range of non-communicable diseases. And when I say that, I mean the formula that we've used, our mixed methods, qualitative and quantitative approach, we think is something that can be rolled out for other NCDs. So why is health economics so important for our global health research group? Well, I've already spelled some of that out already. We know that the disability burden is immense. Musculoskeletal conditions are the second most common cause of disability, and rheumatoid arthritis is the most common type of inflammatory musculoskeletal conditions. Quality of life of MSK patients is lower than other NCD patients, and there are important broader impacts of musculoskeletal conditions. Healthcare costs, huge productivity impacts, quality of life and well-being, but these are often overlooked by scientists. So we have actually gone about the process of identifying, measuring and valuing all of these wider impacts. And for intervention implementation and evaluation purposes, we know that we need to establish the likely costs and cost effectiveness of interventions alongside quality of life. So essentially what the study has done is given us some baseline estimates. Okay, and hopefully our study will inform policy developments in Tanzania. So just a very brief, the current situation in Tanzania, very limited rheumatology capacity. At KCRI in Moshi, where our study is being carried out, any identified patients in this area fall under the orthopaedic trauma or general internal medicine dermatology department. Before our study, there was no rheumatology or arthritis clinic at all, and very limited treatment options available other than pain relief. So we've carried out a mixed method study, qualitative and quantitative components. We carried out a rapid ethnographic assessment. Chris Bunn and his team, Emma Laurie and Elizabeth Masoka in Tanzania, carried out semi-structured interviews and focus groups. This was set out at the start of our study with a view to understanding the language and the understandings of joint pain, and that very much set up our whole study. This was followed by quantitative elements of hospital and community surveys, where we have a really complex 3-tier clinical screening sort of triage system, the way that we captured the data, and we have within that embodied a detailed income, productivity, health economic and quality of life data capture. So we, in the community survey, our sampling strategy, I've got Manuela here with me to answer any questions. We use rural communities in the High District plus 1 urban community, Majengo. Manuela designed a 2-stage cluster sampling method with probability proportional to size, and we were very lucky to have experienced researchers in Tanzania guide us on the use of the Balozi infrastructure, where the village leaders were helped to enumerate the households and to inform the villages about the aims of the survey. And obviously the statistical analysis took into account adjustment for within cluster household village homogeneity. So this is our very complex 3-tiered plan for going through our community survey. So tier 1 was to administer a bunch of tools, including demographics, child health utility index, health economics questionnaires, and the pediatric GALs. We administers other burden of disease instruments, the HUDAS and the GALs, which is the Gates. Just completely blanked. Gait, arms, legs, spine screening instrument. And for those that were GALs positive, they were then given the tier 2 survey tools, which were the health assessment questionnaire, global health assessment, joint pain, joint count, and the REMS, which is a more specific regional examination of the musculoskeletal condition. And then, depending on REMS positivity status, they were then gone into a tier 3, where there was blood samples, ultrasounds, and long form health economic questionnaires. So all pretty complicated, quite a lot of design at the start, but what we're seeing now is hopefully the results of a nice design. So just for the health economics, we split our questionnaires into quality of life. So we have EQ5D and the Child Health Utilities Index, but we have a number of sections around labour, health, income, wealth, and lots of other questions. So these were our health economics research questions. What are the quality of life and capability, well-being impacts of arthritis in the Tanzanian population? What are the productivity and income impacts of arthritis in the Tanzanian population? What are the health-seeking patterns of people? What are the health-related expenditures? And what is the overall cost of musculoskeletal and arthritis? And is rheumatoid arthritis a predictor of catastrophic expenses? So the only thing I will say on this slide is that we did find at the very start of our study, during the qualitative work, that the capability wellbeing instrument we planned to use was not relevant to our population in Tanzania. So that was dropped quite early on, and that became the focus of our one-year extended study, which is currently ongoing. So I'm just going to talk you through some of Chris Bunn's results here. Chris and Elizabeth and Perry carried out the qualitative work. It's really, really interesting, so it sets us up nicely. So the aim of the qualitative component was to find out how is arthritis understood by community members, healthcare professionals and patients in Tanzania. So they carried out a rapid ethnographic assessment over 30 days, 60 brief interviews, 2 communities and lots of photographs as well. And focus group discussions, presenting words for and understandings of joint pain, and so on. So what is joint pain and what causes it? So these are some of the initial results, and this is all currently Chris and his team are finalising these results, but I just wanted to give you some insights. So the words cold disease, old age disease, disease of the joints, gout were all words that were used to describe joint pain. People's understanding of causes were included exposure to the cold, old age, alcohol and red meat consumption, witchcraft was mentioned, demons, sitting in one position, gender, and so on. So really interesting early insights. Who gets joint pain? So older people were identified by the majority as those who suffer from joint pain. Women were also identified by large numbers of participants as experiencing joint pain. And the occupation, some people mentioned butchermen as likely to experience joint pain because they work in the cold and chop meat. How does joint pain affect people? So the economic impacts in the family was regularly mentioned. Disease has a lot of negative consequences for the individual. People are unable to work, can't do anything for the family, so on. So very prevalent across our interviews, this was coming up, and the cause of new conditions as well. How does joint pain affect people? So loss of mobility, people can't move fast, can't work, and so on. So lots of really nice understandings here. Other consequences mentioned there as well. What do people do about joint pain? So these results here, people with joint pain attend the hospital to see medical doctors, buy medication from pharmacies, and so on. Herbal remedies were also mentioned. And traditional medicine was mentioned quite a lot, and they do refer to this as a cold disease. The use of traditional healers is referred to there. What do people do about joint pain? Take exercise. People with chronic pain sometimes attend the witch doctor to find out why they haven't been cured, and also spiritual solutions. So really, really interesting findings here. So Chris and his team have basically understood that there are 10 languages identified in focus groups. They have identified 154 words associated with joint pain. Understandings of joint pain are syncretic, mixture of folk and biomedical conceptualizations, dominant narratives about those who are affected by joint pain, older people and women. They map very closely with the epidemiological picture in our pilot survey and also in the global literature. The consequences of joint pain in Tanzania are diverse, but they seem to be well understood, and loss of mobility leading to socioeconomic consequences. Clearly, we found that in our qualitative findings. So I know it's a bit of a whistle-stop tour, but it's nice to set up the quantitative work that we've done. So what I'm going to do is present some initial findings of our community survey. These are currently being analysed, but we do have some findings from that large community survey. So the first aim was to conduct a prevalence survey. So we've really kind of tailored that around the GALS and REMS screening tools. So prevalence of GALS and REMS, we're finding in the field around 8% for GALS, and the more specific tailored REMS instrument is picking up a prevalence of around about 6%. For the quality of life, we are finding for those individuals screened as GALS positive, we're finding a significant reduction in quality of life. And if we look there at the REMS positive results, now these are the people who've screened positive to the regional examination of the musculoskeletal system. We're seeing very similar, so almost 20% reduction in quality of life for those with that positive screen. So quite significant there. Just looking at the initial health economics results, we can see that people who are GALS and REMS positive are impacted by the number of work days that they can carry out in the last 3 months. Again, significant reductions there. People who have had their work affected in the last 7 days, very clear differences also, and other daily activities are being affected by these conditions. So this is the latest. This literally has been sent to me this morning by Manuela. So we do have some total healthcare cost estimates. These are the predicted costs of total healthcare, and we can see that in our MSK group versus our control group, we do have very large and significant differences in loss of productivity, outpatient visit costs, costs of traditional healers, hospital stay, transport costs, and also the opportunity cost of transport. We've used NIHR Tanzania unit cost sources, and we're currently just playing around with different unit costs to see whether there's any sensitivity to results, but this is ongoing analysis. But the important thing here is that we have been able to measure and identify quite significant differences in total healthcare costs between our group with MSK and those without. So just to give you a brief summary of the findings, we have identified the prevalence of GALS positive and REMS positive in Tanzania, around 8 and 6%. We've found large reductions in quality of life with GALS and REMS, almost around about the 20% mark, which is really quite significant. And we've also been able to measure the productivity impacts. People with GALS and REMS should be positive, working less days, taking time off due to illness and other daily activities, and huge household spend on healthcare. So just almost my last slide here, just to say we've also spent quite a lot of time in training and capacity building. So we've got a new MSK clinic set up at KCMC. We have a number of people who've been trained by our clinical team going out to Tanzania. Our student Natea has completed her MSc in Global Health with a distinction. We have a number of team members conducted the EULAR, European League Against Arthritis online courses. There's been 2 bursaries and foundation ultrasonography courses completed, grant writing courses. 14 people have been through the clinical training on GALS and REMS, 6 people have been through ultrasound training, 44 through field training and data collection. We've had a number of people trained in social science research. I think that number's actually gone up now. We just completed it there in January. A number of project equipment donated, and we also have obtained a Glasgow University Knowledge Exchange grant recently, where we are developing training videos for GALS and REMS for our African context. So that's all underway just now. There's a lot coming to the end just now, so it's going to be really exciting seeing these final results. And there's the global health team. That top left there was we were all out in Tanzania right at the start of the study back in 2018, and there's some of the training going on. There's Natea, and on that far right there, that's the team. That's Kajaru and Natea and Sanjura, who came over to the British Society for Rheumatology about 2 weeks ago, actually. So it was great to see them here in Glasgow. So that's a pretty quick tour of our ongoing analyses and our study. And if anybody has any questions, we've got a few minutes to. Sorry, it was a bit speedy, but I know I'm conscious of trying to fit it in half an hour because.
Well, Emma, can I kick off if there's nothing online? So if I were to put my NIHR hat on, I think as a funder, NIHR would be very pleased and impressed with the achievement from this project. It is really impressive what's been done and what's still to come. I do have a question. I am surprised by the health utilities that you've recorded from the groups. I can see there is a difference, but generally they're quite good, quite, 0.87. If you think, what is the population norm in Tanzania? And if I, thinking further ahead, the reason why we want to understand health utilities in this group is, if we were to introduce an intervention, what kind of improvement should we be aiming for? And the baseline seems already quite high for people with musculoskeletal conditions.
That's a great question, Lou. I mean, this is the first time we've captured these data in this population, so we don't really know what's going on. We did have deliberately an embedded control group to give us that contrast, so we do know that we have that reduction. We have to now work forward at looking at how we benchmark this, as you quite rightly say, whether there's been an element of sort of normalization, of habituation of this, that might be partly to explain some of this. I mean, it's still a huge reduction, but yeah, those questions you've raised are really important, and they will be topics for discussion going forward in the next 6 months. And in terms of population norms, I mean, I'm looking around at Manuela and Eleanor. I don't know that we do have those data available on population norms for the setting.
Well, there are not like population values for Tanzania specifically, but we're using the Uganda, Zimbabwe, Ethiopia, and the UK one. So there are there are differences using different population norms, but still using all these value sets, there are still significant difference between the the control group and the REMS positive group.
Yeah, and I mean, and also, Olivia, just on your point about going forward to intervention, this population doesn't even have access to, current therapeutics like biologics. So there's a lot of work to be done in terms of just even getting the basics in place. So when we talk about interventions, we're talking about, basic drug treatments, and those are obviously the next steps. I think what we've done with our study is really lay out the problem. And hopefully there's a lot to be done now.
I just wonder whether the EQ5D is undervaluing the impact.
So good question, and that's partly why we did decide to build in the capability wellbeing instrument as well. And we have other instruments. We've got the HUDAS, and all of these. They're all currently being analysed as well. So we've got other measures of burden that we'll be able to report quite soon as well. So we'll be able to triangulate all of these measures of burden that we have, and actually we do have the HUDAS results, I think. They're still being finalised. Yeah. So those are the first estimates. But yeah, I mean, it paints a very bleak picture of significant quality of life impacts. And the capability wellbeing, as we say, we've got this, we had to drop at the start because it was not fit for context, but we've been doing this extended work now in Uganda and Malawi, actually, with Mia Crampon's group, and we're looking forward to finding the results of that the next few weeks, actually. Yeah, please do.
So basically, I can see this is a massive work, first of all. So my questions are specific to the economic burden, which you are trying to measure under this. First of all, what are the indicators, outcome indicators you have decided particularly for this? Second, you have taken the data on the income, right? And the purpose seems to be that you are trying to measure the productivity losses.
Yeah.
So how willing, to what extent people were willing, those who reported the data on the income, because as far as I know, we have tried to collect this data in the India, and people are generally not very cooperative to report this data. Whenever they report it, it is generally underreported because nobody wants to reveal their income, specifically in the middle class and the rich class people. Obviously, the poor class will report the actual incomes. So that's why we go by the alternative methods, that is consumption expenditure or the asset data-based.
Yes, so we've got the assets as well. So we did all of that. So okay. Really good question, thank you. And we were really mindful at the start of the study that we were conscious that this would be an impact. So we've built in a number of parameters to try to capture that, if you like. And you're right, we have assets which we haven't really done a great deal of analysis on yet. But we're really keen not to just go in with a wage rate estimate, because we knew that the majority of our population were working in agriculture. So we were more focused on how to measure productivity. So productivity estimates are around days, hours spent working and so on. And we do have the standard wage rates that we can use in a sensitivity analysis if we want to. But we were very conscious about exactly that. But I also think that by taking the guidance from our Tanzanian colleagues on what would work, and to reduce any suspicion around this study, we brought in the village leaders and the Balozis, so that they were able to reassure our community that this was all being done, and for research purposes only, and there was nothing to worry about. So I mean, I guess the extent to which the data are true, I mean, it's another study in itself, isn't it? But we were really pleased to find the differentials in ours as we'd expected. So there will be off by a magnitude, no doubt, but I think it's probably the best we could have done.
Sure. So another question in continuation. So basically, what aspects do we cover in the economic burden? Because I see productivity losses are the one thing, but there might be some expenses related to which are incurred by the patient for the treatment of this disease.
Yes, we've captured all of that. That's all in there. Yeah, we measured all of that.
Out-of-pocket expenditure.
Yeah. That was because we were very focused. We were conscious that that people. We talk about catastrophic expenditure, and so we wanted to measure that. So one way that we did that was to capture people taking loans out and borrowing from other family members. So we have captured all of that as well.
And again, another question, I'm sorry. So again, related to this, so if you have gone up to catastrophic health expenditure, which is the indicator of financial risk reduction, so obviously you have designed some kind of threshold based on the income only, right?
So this
becomes very important in this study.
So in terms of the denominator, yeah, exactly, you're right. So that's in terms of how we determine catastrophic expenses. So that ratio of expenditure to income, we were able to look at. And I think that's something that Eleanor's probably currently doing just now, actually. Yeah, a really good question. Thank you. I'm just looking online to see if there's any questions. If anybody has any questions, please just go ahead. I don't see any raised hands. I think we could probably finish there then. There are no questions from the audience, and we could probably maybe just carry on and discuss here in the room. Well, thank you very much to everybody for coming along, and hopefully we'll be able to present some more polished, finished results in about 6 months' time.
Bye.
Bye.